Bismillah ar-Rahman ar-Rahim. Thank you, Dr. Slab, for your kind invitation for being with you today with our lovely ER physician. So today, inshallah, we're going to speak about the incidence report, or sometimes also it is called OVR, which occurrence variance report, patient experience in the ER, international patient safety goals, and documentation. So incidence report. Incidence report it is a reporting system about patient safety issues in the hospital. تنظيم الإبلاغ في المستشفى. And what we are reporting about, so we are reporting about any incidents which happened or which didn't happen. It was a risk. يعني مش بس ان احنا بنبلغ عن اللي حصل، لا اللي كان ممكن يحصل كمان، او any probable risk could affect the patient in the future. We have, so sometimes in the survey he asking you, do you have incidence report or IR or OVR? Yes, we have. Before it was paper, now we have electronic system, and I will come to this later in picture. So when we are reporting the IR, when an injury, near miss, sentinel event, no harm incident, and I will illustrate all this in details later, inshallah, who will report and what to report. So any injury to the visitor or volunteer, if in case we have, the patient or the families or even the hospital staff should be reported. Any incidents which is not consistent to the routine patient care should be reported too. We have some definition. Adverse event is a patient safety event that resulted in a harm to the patient. So the incident happened and reached the patient and harm. No harm event, a patient safety event that reached the patient, but alhamdulillah, nothing happened to the patient. Also should be reported. A near miss, the picture in the right of the two air flight, yani alhamdulillah, they're about to crash, but nothing happened. So this is a near miss or a close call, is a patient safety event that didn't reach the patient. يعني حاجة ما حصل، الحمد لله لحقناها قبل ما تحصل ومسكناها. Should be reported too. A hazardous condition is a circumstance that increases the probability of adverse event. هو مجرد risky situation, but nothing happened from it, but I have to report about it. Sentinel event. طبعا sentinel event, this is يعني something serious. Is a patient safety event not primarily related to the natural course of the disease. يعني حاجة ليس لها علاقة بالمرض العيان. That reached the patient and results in any of the following. أدت إلى death, permanent harm, سواء كان physically or psychologically, severe temporary harm. With definition of the severe temporary harm is a critical, potentially life-threatening harm lasted for limited time. يعني the patient will not be the same as before. Like ممكن يكون wrong surgery, ممكن يكون wrong procedure to the patient أدت إلى lead to that severe temporary harm. Or it could lead to severe life-threatening condition. Maybe the patient admitted to the ICU and he become back again, but it put the patient in a critical situation due to wrong procedure. According to the last GCI, the 7th edition, they put some event which would happen, it would be a sentinel event. So this include a suicide of any patient receiving care, treatment in staff around the clock, or within 72 hours after discharge. At the hospital or after discharge of 72 hours is considered sentinel event. Unanticipated death of full-term infant, discharge of infant to the wrong family, abduction of any patient receiving care, treatment, and services. Any hemolytic transfusion reaction involving administration of blood or blood products having major blood group, wrong blood, rape, assault, invasive procedure, wrong surgery, wrong site, wrong procedure, unintended retention of foreign object after surgery, severe neonatal bilirubemia over than 30, fire flame, smoke, heat, any intrapartum maternal death, severe maternal morbidity, air embolism, serious medication error leading to death or major morbidity, unexpected loss of limb. So any of thing happen like this, it's considered a sentinel event. But if any other incident happened to the patient, we could discuss in the morbidity and mortality committee if it is a sentinel event or not. So if this happened, the staff who attended, he should report about it. So in this slide, we will tell about more about the type of incidents which we may have in the hospital. So I will say the incidents and let's see what could be. So if you're exposed to a needle stick injury, under which category? Needle stick injury, it could be injury. So I will, it's under injury here. If there is absconded patient, under which category you will report absconded patient? So it could be security. Report under security. If you suffer sudden electricity shutdown, it's under supply or under equipment according to the. If there is a child abduction, under which category? Security. If a physical assault, under which category? Security. Could be injury if the staff or the patient have injury. If hematoma after drug injection, which category? So it could be medication, it could be injury too. Patient suffered fall, patient fall. So it would be injury or procedure if we did the wrong procedure for the patient and led to fall, or some also medication, some medication effect for the patient if led to fall. If there is expired item, supply. I'm here speaking all about incidents. So some of related to doctors, some related to nurses, but it's all kind of categories. If the physician violates the rules for appropriate prescription, under which category? Could be medication, could be procedure. If there is drug count variance, under which category? So medication. So we have equipment like electric problem, improper use, mechanical problem, non-availability of equipment, not working, and this is mostly done by nurses. Here about the document, note in wrong file, missing note, no label, wrong file. This is could be done by doctor and nurses. And the missing supply or shortage of supply is mostly done by nurses, but as a physician, you can tell here to do incidents report about it, and you can do it too if you find a missing supply for you or missing or shortage of supply. So all the staff are in charge to report. So not only the one who did the mistake, and this is not some kind of snitching. يعني احنا مش بنبلغ عن بعض. We are seeking for the safety of the patient at the end. So usually the reporter need to witness to confirm his reporting. Unreporting incidents are considered violation of hospital policy. The focus of incidents report will be upon process systems. In quality, we all believe, me and all of CQI staff, we are believing when problem happen to the patient, it's a system issue. We are not blaming individual. We must fix our system to make it strong to prevent any error from happening. So when error happen, report about it. Don't worry, don't be afraid. We are not judging. We just try to focus on the system. We are not caring of the one who report or the one who did the incidents. We're caring to make barriers to prevent the error from re-happening in the future. And we, as always we said in quality, we supposed to be in a blame-free culture. We are not blaming individuals. This is our, I guess all of you know this. This is our intranet homepage. So if you need to go to the incidents report system, before 1 year ago, 1 year and a half, it was paper. Now we have this one. I guess most of physicians are not reporting any incidents report, but just you know to know. This is Sharik here. You will find Sharik. And after you're in Sharik, you will find this one. If you are not registered, you can make registration with username and password. It's mostly the same username and password of the Windows. And if you face any hardness in making account in Sharik, just contact us in CQI and we will help you. So after you enter, you will find the user menu screen. Here you will find your IR form, control panel, new user and analysis. This is for us analysis. IR form, if you press on IR form, you will find here the incidence report form, first date and time and location. You will enter the day and time and hospital area. You can choose by department and you can report by any hospital. By the way, if you go here, you'll find the drop list of the hospitals all, Mansour, Sultan, even Rania. And choose a department, if any section or location in the department. And then you will choose here patient who is affected the incidence. If it's a patient or a staff, visitor or organization, if it's affected many, like patient or staff, you choose the most one affected. So I will choose patient if it is the most or staff. And here, this is optional. If you choose patient, you have entered the patient medical record number. And once you enter the medical record number, here it will give you the name and gender and date of birth على طول. So just enter the number and he will give you the place of the patient. If staff or visitor organization, you need to fill the medical record number. So here, and this is the admission safety taxonomy. So we have a lot of incidents, patient fall, medication errors, a wrong procedure, whatever you eat. There is a lot, hundreds of. So we will just in the search for keyword here. If you write a word, if you write fall here, you will find all kind of fall. So like here, so this is maybe the picture is not. I wrote only fall. So you write all of this: fall from bed, fall from chair, fall from crib, fall during play, development fall, baby child fall. So you choose the kind of fall. If you go here, wrote medication error, you will find a drop list of all type. So this one is built in here. So choose your error. And so when you come here to the area of level of harm, you need to choose level of harm. So when you press on level of harm, you will find none, minor, moderate, major, catastrophic. So the none, so this is the incidence in care, but no harm to the patient. Minor effect, no change in vital sign, non-invasive diagnostic test required, increased observation required. So the patient only need observation or monitoring, but his vital is the same. Moderate level of effect, so vital sign change, decreased level of consciousness, additional medication treatment, or invasive diagnostic procedure required. So this is the moderate effect of the incidence. The major effect of the incidence, any unexpected or unintended incidents that cause permanent or long-term harm. This is major. Catastrophic is mean this. So here you will choose level of harm according to your judgment and the likelihood of the incident. So the likelihood is how often this incident happen. If it is rare, this will probably never happen or never happened before. ما حصلش قبل كده. Unlikely, we don't expect it to happen. Possible, it might happen to reoccur. Likely, it will happen or reoccur probably. And frequent, it happen a lot. So it is this is depend on your judgment. أنت بتحكم. And after that, we are in CQI. We are going and to check about it. We can change it. But this is your personal judgment of the incidents. So here, you will put the type of incidents, and this one is come automatically after it, level of harm, as we said, and likelihood, and then this risk score is calculated automatically. Okay. After that, there is an event description. You have to describe your event. So you write. So I when I was dealing with this patient and giving him management, the patient fall from the bed, and you write detail. And here we are supposed to do corrective action. Any incidents happen, if I can fix it on time, I will fix it. So if I could fix it, as I said, we did this and we fixed like that. If I couldn't fix, I worried we couldn't fix it. Something you couldn't fix it. So just write, we didn't do any. We didn't fix this problem yet. And you will find at the end here, submit. You will submit. Okay, this is our incidents report. And by practice, you will become more expert because I know some of you are doing, and the nurses are very expert also about that. So after any incident report or any sentinel event or any severe risk could affect the patient, we make what is called root cause analysis. This is supposed to be done by the team. Dr. Islam will make a team of you, and if you could need to invite one of the CQI, we would like to, and we will see what is the root causes of the problem. We have to dig to see the roots of the problem. And now it is called RCA square, root cause analysis square. We have to do root causes to see the causes which led to the problem and do action plan to prevent it from happening. This is could be done on departmental level. It's okay. So if the patient acquires comorbid condition, under which category? So if the patient have comorbidity or mortality, also have to report what is called morbidity mortality. This is have another form of report, and so it should be discussed in the departmental monthly meeting and could be escalated to the regional committee, the hospital committee morbidity and mortality. This is morbidity and mortality report. This is different than incidence report. So if any morbidity or every mortality case should be discussed and have reporting to the head of department. So patient experience. Any questions so far؟ الدنيا واضحة ولا؟
تمام يا دكتور أحمد.
ماشي. Patient experience, this is a new term came maybe 3 years ago to healthcare. Before it was called patient satisfaction, but now they changed it to patient experience. In the hospital we have, and we are not measuring it, now we have third-party company. It's a شركة international company called Bresgini. After all the patient discharge from our facility, from ER, from OBD, from inpatient, they select a sample and sending them SMS message. I guess some of you could get it from when he visited the employee health clinic. And then they asking him question about the hospital. And to be honest, I'm not blaming anyone here. Our result in ER is the lowest result in all MSD hospital. I guess we are 54% of the patient experience. Patient experience means that the whole journey of the patient from entering the hospital until the discharge, and it have multiple questions, multiple domains, and we will discuss it in details. So the الموضة دلوقتي في الصحة ان هو بيتكلموا عن حاجة اسمها البيشنت سنتر كير. We should share the patient and his family in every decision, discuss with the patient, with the family, with our intervention and our option, and give him the chance to choose and to reject. Must be engagement of the patient and his family and his friends in the treatment plan, and should be informed about every step, about everything. And what is called now about co-designing, bringing even the patient. Some hospitals are bringing the patient. Some committees of the hospital have patient representative in the committee of the hospital. It is called patient advocate, but we don't have here. So this is a questionnaire which is sending to the patient. So first asking who is completing, asking him about the waiting time. Some of them are related to physician, but I will speak about it all in ER, so you are oriented what ER. Waiting time before staff noticed your arrival, asking him, and helpfulness of the person who first asked about your condition, comfort of waiting area, waiting time before you were brought to the treatment area. So to waiting time before he went to the physician, waiting time in the treatment area before you were seen by a doctor. And the scale here, we have Likert scale from very poor to very good. This is the nursing side, the courtage of nursing, degree in which to which nurses took the time and listened to you, nurses' attention to your needs, nurses' concern to keep you informed about your treatment, nurses' concern for your privacy. And here is the doctor part, courtesy. الدكتور كان مهتم بيك, doctor concern for your comfort while treating you. Degree which doctor took time to listen to you. The doctor concerned to keep you informed about the treatment. It's mostly about communication skills. يعني أنا I know and I يعني مقدر جدا that the doctor in ER are very stressed and before there was a big shortage, but this is what is sent to the patient. The doctor have to smile to you ويتكلم معاك ويشرح لك ويوضح لك. فدي الأسئلة اللي بتتبعت الناس. هنا this is about lab, not about ER, and if he did some lab, did radiology, and here about the family and friend. The courtesy was which family or friend were treated. So we have to also sharing the family and friends. Staff concerned to keep you family and your friend informed about your status. Staff concerned to let family member or friend with you while being treated. يعني لازم حد يخش معايا we didn't prevent them from entering there. But يعني مش العيلة كلها يعني واحد بس ولا حاجة. هنا we're asking about the parking, about the food, the rooms, the linen, the bathroom clean or not. And we have to inform him about delay. Are you informed about delay? Degree which staff cared about you as a person. How will you about pain control? Inform you were given caring for yourself at home. This is يعني هل بيديك بقى معلومات when discharge give you enough information and overall rating of the hospital, likelihood of recoming to emergency department. I know some of you could think this is one could be for private more than our governmental sector, but we are implementing now this for 3 years in all MSD hospital, and we need to work as we can to improve it. Now, the third part of the lecture is the international mission safety goals. This is one of the major area in the GCI accreditation, and one mistake on it is not accepted for the surveyor, and it could lead to the serious issue for the hospital result. First one is identify patient correctly and of communication. Number 2, improve the effective communication. Number 3, improve the safety of high alert medication. Number 4, ensure safe surgery. Number 5, reduce the risk of healthcare associated infection. Number 6 is reduce the risk of patient harm resulting from fall. طيب, patient identification, what I need, I guess most of you know that we are identify the patient by two identifier, patient medical record number and full name. Patient identification should be done before providing any treatment such as administering medication, blood or blood product, administration of serving diet trays, providing radiation therapy if we don't have in our hospital, but this is the policy. Performing procedures such as insertion of intravenous line, central line, before any diagnostic procedure such as taking blood or other specimen for clinical testing or diagnostic surgery, labeling element associated with the patient, all the document of the patient and all his sample, blood sample, pathology sample, dietary tray, mother milk for the babies should have identification, patient ID. For ER, one of the most thing is related to ER stuff in patient identification is the comatose patient so in ER, we are giving all the ID band. I guess if the patient is awake, we ask him, and we should involve the patient directly. You don't ask the patient, is your name is Muhammad Ali? No, you're asking him, what is your name? Don't give him a indirect question. So direct involvement of the patient. So ID band for the اللي هم البيشنت اللي مش كوماتوز الفايقين يعني. لو unknown patient مش عندنا او كوماتوز مش عارفين ناخد بيانات، وانت على حسب هنا بتاخد اعتقد دي مطبقه عندنا دكتور اسلام بتاخد 4 ايز صح؟
ايه دكتور
مظبوط
احمد،
كده.
مطبقه في
عندنا
القانون
السياسه في المستشفى
والكوماتوز.
بتطبق كده بياخد بتطبق صح؟
ايوه تمام.
تمام، دي سياسه المستشفى بياخد 4 ايز والسكند ايدنتيفاير will be identified number In case of several unknown in the patient ER, each patient will receive 4 letter, ياخد 4A, then 4B, 4C, and after 26, like it will be 3A, B, 3A, C, and so on, and so on. In the event of patient disaster, Dr. Tim is expert in this point, and I know he's doing how to giving patient number emission according to our plan, and you did the committee today. Before doing any procedure to the patient, we identify the patient. How we identify the patient? By patient medical number and full name. We never identify patient by bed. We never identify patient by room number. Never, not accepted. Communication, how we are improving the communication. In this, we have 2 points in the communication. We have verbal and telephone order. We have handover. Verbal communication of order should be limited to emergency situation, and I guess you are in emergency department. So where immediate written is not visible. So emergency cases, we can accept verbal order. Telephone order should be limited to urgent situation. يعني not accepted in emergency situation where the authorized provider is not physically present. Verbal and telephone order, and this is our policy, by the way, and there's some point I want to confirm me it is done or not, because I am not sure. So physical, verbal and telephone order will not be accepted for this situation. Physical restraint should be ordered by the physician except in emergency, which it can be initiated by the nurse until physician in order to obtain. Like if the patient is very agitated, something like that, and the doctor is not around, initiating TPN therapy category in the DNR, withdrawal of life support, chemotherapy, which we don't have, narcotics, ventilator, blood transfusion, high alert medication, multi-drug dosage, including antibiotic, releasing of patient DAMA. I gave medical advice. I don't know in high alert medication in a restroom, you are not accepting verbal order, Dr. Islam?
We are accepting verbal order in case of code.
الكود بلو بس.
Yes.
تمام. And over. So suppose there is the nurse is using this bar. Suppose every department assuring that there is handover between every shift and the next. So I don't know, before we using paper form, are we still using the Islam and the handover between, and it is documented تتحط في مكان.
Yes, we have the physicians are filling up some special form in endorsing patients between shifts, and sometimes now after application of the electronic medical file, we can document the endorsement in the patient's file.
يعني there is no special now, there is no special form regular يعني.
There is special form, but since February we started to fill the electronic file, and the endorsement is documented in the electronic patient file.
طيب خلاص let us see it later مع بعض. تمام. نعدل السياسة.
إن شاء الله.
Reporting critical result in emergency room. So suppose to, if according to our policy, if any critical result, the lab calling the main responsible physician, and the main responsible physician should document this one in the patient medical record by reporting of critical result. And I guess the nurses are doing this, but according to the policy, it should be done by physician. And if the ER nurse did ECG, CBG, and she see a critical result, she should immediately inform the ER physician. And the doctor must document this in reporting critical result. And what I hear also is the nurse is doing it, but it should be filled with a special form for this critical result. And if, according to the policy, if the MRB, but I guess because ER doctor are 24/7 hours there, so they always define someone. But in the other department, if the main responsible patient didn't answer, they are calling the head nurse. If they didn't answer, calling the head of the department, didn't answer, the medical director, and 5-minute interval between everyone. It's according to the policy. But I think this never happened in ER because you are always there. And high alert medication and concentrated electrolyte, it's mostly this one for nurses work. But I need you to know we have list in our hospital for high alert medication, list for concentrated electrolyte, and you will find it in the medication room. And just to know, you have this one, and this is have a special يعني في storage والadministration. But in doctor we have to care. We don't write abbreviation in ordering. We don't write prohibited in prescribing it. يعني لما نيجي نكتبها ما نعملش اي abbreviation مش واضحه، يبقى كلام واضح، الجرعه واضحه، بدوز واضحه، عشان ما نلخبطش النيرس. Any prohibited abbreviation we shouldn't use. What they mean by safe surgery, that we are doing not only surgery in the OR, but any invasive procedure. So we have to be sure that it is done in the right way, and what is called timeout should be done before any invasive procedure. So this is the four we mentioned: the nasogastric tube and intravenous cannulation, arterial line, urinary catheter. This is not need any site marking, but any rather than this, it is required site marking. So the surgical site should be marked in the ward. And if it is going to OR, site marking should be done for all patients having any invasive or surgical procedure that involve any laterality, and in the right and left, multiple structure, fingers, toes, lesions, multiple levels, like the spine. And the one who do the procedure, who should the one do the site marking. And our site marking in hospital is arrow, not X, not علامة صح. So what is have exemption of the site marking? The premature infant, because it could lead to dental surgery. They are doing it on the X-ray. Any entry midline orifice like rectal, urethral, vaginal, oral. Invasive case for which catheter and instrument site is not predetermined. So we don't know. We will put the central venous line, arterial line, we don't know yet. Pulmonary artery catheter. The single organs like C-section and cardiac surgery. In the emergency or urgent condition in which the individual doing the procedure is in continuous attendance with the patient. قاعد مع العيان من ساعة ما قعد لحد ما هنعمل procedure until doing the procedure. So خلاص أنا مش همشي وأسيبه يعني، أو حتى أو هرجع. So this one in this condition, no need for site marking. One of the IBSGs, one of the most important thing in my belief is the hand hygiene. Not only for you, for the patient, it's for you and for your family, not getting any infection. So when we know the 5 moment, the 7 steps, and there is hand, this one I will speak about inshallah in detail in the infection control, but just in brief, when we do the hand hygiene before touching patient, before clean or aseptic procedure, after body fluid exposure risk, after touching the patient, or after even touching the patient's surrounding. So this is the 5 moment when I do hand hygiene. The steps is, you will find it على كل حوض, every zinc you will find the steps. You have to follow the steps, and we are measuring our hand hygiene, and we are sending, by the way, all of this IBSG are measured, identification and overall are measured, and we have KPI, key performance indicator in all. And our result in hand hygiene is 72, and I believe it not more than 20%. And in the surveys, we have also MSD coming to us. They are noticing the doctor, in an indirect way. They are noticing you. Are you doing hand hygiene after touching patients in the 5 moment? Are you doing it right or no? We have also what is called standard precautions, which is basic hand hygiene. We said the personal protective equipment, gloves, goggles, and gowns, mask. Safe use of disposable sharps should be disposed in the sharp boxes. Routine environment cleaning, this is by the nursing and housekeeping. Respiratory hygiene and cough etiquette, this is very important. Aseptic non-touch technique. And also we have the waste management. We have to separate our medical and non-medical waste. We are not supposed to put the medical waste in the non-medical waste, and vice versa, not accepted. And also we have standard precautions should be used in handling of any blood and blood products. And for every type of, have We have the airborne, the droplet, and contact precaution. This is, we'll speak about it later in the infection control lecture, inshallah. Can fall for, as a physician, you in ER, we have to know that we are doing patient, the nurses are doing full assessment and reassessment, and she have to inform you. And if the patient need any assistant, need to be, have to prevent it, any risk, the nurse with the doctor together, they have to work to prevent from any fall, old age, or if giving a medication which could affect the consciousness of the patient, we have to inform the nurse, and we have to take care from preventing the patient from fall, old age, comatose patient, and any have risk. But this is done by the nurse, but the doctor should know it. Documentation, this is my last slide. So ER documentation, this is the standard in the GCI. The medical record of patient receiving emergency care includes the time of arrival and departure, the conclusion at termination of treatment, the patient condition at discharge, follow-up care instruction. The patient receiving emergency care include arrival, departure time, this information is captured for all emergency department patients, including those who are discharged from the hospital, transferred to other facility, or admitted. يعني even also this is point in the دايما بنلاقيها في اخر البتاع اللي هي disposition راح فين احيانا مش not filled. Departure time may be when the patient physically leaves emergency department to go home or another facility, or time which the patient is moved to another unit. For patient who are discharged from ER, the medical record include conclusion of termination of treatment, the patient condition at discharge, and follow-up care instruction. And one of the question of the continuity of care, when the patient should come back to you. The medical record of emergency have arrival time, and departure medical record have conclusion. يبقى عندنا departure time, arrival time, conclusion, patient condition at discharge, and the follow-up care instruction. This is very important. And I believe this is not only for the sake of the patient, this is the sake of the physician. يعني لا قدر الله, if any problem happen and medical legal, your documentation will be reviewed. And this is for your safety and for the safety of the patient. So full documentation is required. And alhamdulillah, in ER, you don't have many forms to be filled, unlike the other inpatient. But in every survey, we have some finding. I know this is, I'm a physician too. We don't like to write, I know. But, for the, inshallah, for preventing any problem from happening in the future. So we have to complete our documentation. I'm done. Thank you. Any question?